All right, everyone. We've made it. The final day. Let's have a little round of applause. So it's been a great week. Today's structure is very similar to the previous afternoon sessions. And then what's going to happen is that everyone will be free to go get your hair, makeup done, your nails, whatever it is you'd like to do before the 7:30 kickoffs start. I like the shellac, all the different ones, yeah. If you do have any questions at all relating to what will occur tonight, where exactly it is, just come up and see one of us and we can show you on Google Maps exactly where it is. But the corner house seems to be pretty well known, so if you do get lost or unsure where you're heading, just ask anyone or just say transport and people just appear out of nowhere to take you. Today, I'll throw to Kim and Sue very shortly. Just before I do so, you'll notice that you have some QR codes on your table. So this year, it's been quite the challenge trying to get a conference together with COVID, international travel and everything else that's sort of going on. And so really appreciate all the effort that every single person's been to get here. Next year, we're looking at making this event bigger, grander, but we really need your help to dictate what that looks like. So the QR code there will take you just to an online survey form. We really do take all your feedback on board. We have a look through it, so please add as much info as you can there. If you've got any suggestions, what you'd like to see next year or any other future conference, please let us know. That would be a great help. But you're probably sick of hearing my voice. I've been talking all week, so I'll throw now to Kim and Sue to talk about mental health patients in the acute setting. Let's hear it for Kim and Sue.
Hi everyone. Thank you so much for coming to the last session. We didn't know how many people would be here today, so hats off to you guys, and I hope you enjoy your brains. If you get a bit stressed throughout the talk, feel free to squeeze them. There's some Aussie lollies on the front of the stage too. If you get more interactive, there's more lollies there. So yeah, what a great place. How nice to be back to Bali, and how nice to be able to fly here now that COVID has kind of settled for us as a world. We really appreciate Dylan and Quentin asking us back. And today we're going to try and make it as interactive as possible. Please feel free to put your hand up, ask questions, give comments. The more interaction, the better for us, and we will actually get you towards the front very shortly. But just to give you a bit of background, Kim and I are mental health clinical nurse consultants on the Gold Coast. We've probably spent the last decade doing very similar things, so we won't go past the last decade. We've been working mainly in the emergency department as mental health nurses doing acute assessments. And from there, in 2019, we briefly presented about our rapid response model, which was about greeting and meeting our clientels that came in through the emergency department through emergency services. That role has now been disbanded, and as a further ED avoidance strategy, we have now moved into the QES corresponder role, and QES being Queensland Ambulance Service, as we do come from the Gold Coast, Queensland. I know other states have this model as well, and that's in an effort to try and reduce the anxiety in our population mental health customers, to try and do the assessments at the home. So we will respond with one of our LaRue officers, one of our lovely partners from the ambulance. They'll pick us up at lunchtime at about 12 o'clock. We'll actually go out and respond to the 000 calls in the community. I think our current stats say 65% of the people that we're seeing, we're actually keeping out of hospital. So we're pretty proud of that. So that means less than, over half of the people that we see are actually not having to come to such an anxiety-provoking area such as the emergency department, which is full of, noise, stimulation, people running everywhere. And it's certainly not where I would like to be if I was in a crisis. We pride ourselves in being very flexible. We've seen people up trees. We see them on rooftops. We see them throwing stones at us occasionally. And poor Kim, just before we got here, was heading over a fence to see somebody and cut herself. So, we try to be very flexible in the way that we see people and try and sort of avoid the way that we used to do rigid mental health assessments in the emergency department.
And I'd just like to add to that, part of that is also, we also work with Queensland Police Service doing the same role. So not only working just with the ambulance, but also working with the police. And we often can self-select from the jobs on both sides with the ambulance or with police, or sometimes comms may allocate to us to see if we can go out and see somebody. So lots of the agitation and aggression we will talk about very soon. We're actually trying to manage in the community, and I think it's a really good collegial, collaborative relationship that we've got with the two services, and it's about upskilling each service, I think. So our LaRue officers are actually saying that it's actually teaching them how to manage these patients when we're not on shift with them much better. They would normally have to bring them to ED, and now they can do the assessment themselves and leave them at home with some support.
And they certainly teach us a lot too, because I think we end up doing at least one medical OOO per shift, which is really enlightening for us as well. So it's an amazing collaboration, and we're really proud to be part of that. We'd actually like to see whether we could get you all up the front. Would that be possible, just to come into this little area? And we're just going to do a bit of a warm-up exercise, because we know how comfortable you're feeling right back there. We don't want you to feel too comfortable.
You can't have a session by a mental health nurse that doesn't make you move. The picture's just up there too. It's just a snapshot of Sue and I. So on top of what we do with the ambulance service and police, we actually spend a lot of our time educating overseas as well. So normally pre-COVID, we go to Vietnam and we upskill the mental health and the medical teams over there in ways to manage mental health in their own country as well. So that's part of the role for us as well. And we do bounce off each other a lot. So yeah, hopefully you'll enjoy that.
So I would like to try and divide the room up into, let's see how we go, paramedic ambulance on one side and ED and allied health staff or partners, friends on the other side.
So which side is which?
Let's see how we go. So the left-hand side of the room facing us, you ask tricky questions, is the paramedic side. And
are you on the right side, people?
And the right-hand side is the allied health staff, the amazing ED staff and allied health staff partners as well.
Can I just also ask, is there anybody that works in mental health specifically within this group? Ah, well done, thank you. Last time we were the only two here from mental health, so welcome.
All right, now, I think we're pretty evenly fixed. Do you think you could just walk across to the room and just eyeball one person and stand opposite them, please? Just meet somewhere, you know, normal distance, COVID respectful. Just find someone that you don't know. You're just going to ask them a question. If you can't find one in the other group, find a different one. That's it. Has everybody got someone they don't know? All right, I'm going to come up here. You guys are being cheeky.
Have we all paired up? Does anybody need someone to pair up with? Put up your hand if you don't have someone.
Who hasn't got a friend? Ooh. Ooh. Shh. Who hasn't got a friend to speak to?
Yep. Here, you've got me. You'll have to pair up with me now.
Okay. Really, really nice, simple one. I know you feel uncomfortable out the front of the room, and I'm sorry about that. I feel uncomfortable up here too, so I'm just helping you to make me feel better. Could you just ask the person in front of you, you can do it quietly, or just tell them something that they wouldn't probably know about yourself. Whatever you think's okay. It doesn't have to be awful or dirty or anything, just something they wouldn't know.
I can't speak Dutch. Sue can speak Dutch.
Oh, okay.
All right. How'd you go? Ooh.
Oh, wow.
Shh. Good job. Okay. Last one. Can you tell that new friend of yours something that's been really embarrassing for you but you find difficult to speak to people about? An embarrassing thing. Look, the other day I was at the gym and I fell upwards up the stairs with my drink bottle on my face. You know, it's really embarrassing. We all have things that we do that cause us embarrassment, causes anxiety. Just pick something.
Okay.
Okay, are we done? What have you learned about your new friend? Was it anxiety provoking saying it? Was it a bit scary saying something to a stranger that you've never met before? That's a smidgen of what our mental health patients, and all patients, I guess, that we see, whether we're paramedics or whether we're nurses, whether we're allied health professionals, a smidgen of what the people that we see must feel. And I think it's really important to remember that being embarrassed is something that happens to us all the time, but then go the next step. Go to that anxiety, go to that, I don't want to be here, I don't want to answer questions to this strange nurse, to this strange paramedic. Just gives you a little bit of a feel of what we're going to start to talk about today. So thank you for being honest. Does anyone have a really cool story that they're allowed to share about the embarrassing moment before we go back to our seats? You have to give permission. There must be consent. No?
That's all good. Maybe tonight you might want to share that.
No, he's not prepared to. No, we need to protect one another. Thank you very much for participating, coming all the way down the front.
Okay. So we'll just wait for you all to take a seat and we might make a move into it. We are going to get Quinton and Dylan to cue us because we tend to go off track a little bit and we're going to try and keep on track today. And we are going to try and get through a fair bit, and it's probably nothing new, but it's just a refresher today. And as Sue said, it's, you know, that warm-up is really imperative to know what mental health patients feel like when they're being asked questions in front of an audience, really, because that's what an ED environment is, or that's what it is when a paramedic goes to them in the community. And we're asking them to share really personal stuff with us, first up, which most of us wouldn't share. Or if somebody's really angry, you know, if we can think back to a time when we get angry, you know, what works for us and what doesn't. I know if I'm angry and you're towering over me and asking me questions, I'm likely to try and, you know, slap you one. I'm just, you know, that's me, so don't get close. Okay, I've just started off with a, if the clicker works, a quote. So I call it food for thought, and I love this quote by Matt Haig. So it says, mental health problems don't define who you are. They are something you experience, like you walk in the rain, you feel the rain, but you're not the rain. So I love that quote because to me it really sums up what mental health is. Mental health does not define you as a person.
Alrighty, I'm going to just run through really quickly the introduction and our schedule for the next little while. What is mental health? That's what we'd like to have a brief WHO definition of. We're going to look at challenging behaviours in the acute setting, preventing challenging behaviours. Not that we can prevent them, but sometimes we can make a difference to a different outcome. Communication, helpful strategies, and these are all things that you all know. So we're not trying to teach you things, we're just trying to get a revision happening and maybe a reflection of the way that we are with our patients and the way that they behave towards us and the reactions that we actually give to them. Conditions, particularly some medical conditions that cause aggression and agitation. Agitated consumers. We're going to talk a little bit about acute psychosis. I'd really like to have a look at a case scenario which is interactive with you guys. It'll start from the community and then we'll follow it through to the emergency department. History taking hints. We're going to talk a little bit about diagnostic overshadowing. Decision making, particularly in the ED, where to from here, once we have this person, what's the most important step in treatment for them? And if we have enough time, we might touch on borderline personality disorder, which is, I know, a request from quite a few of you from the last time that we were here. If you want to particularly do that and we're going too slow on some of the other ones, just give me the wind-up thing and we will move forward to that. Okay.
So what is mental health? So the World Health Organization defines mental health as a state of mental well-being that enables people to cope with the stresses of life, realise their abilities, learn well, work well, and contribute to their community. So I think everybody can relate to that. It sums up mental health. Mental health isn't a psychotic person. Mental health isn't a psychopath that's running around killing people. We also know lots of populations that are at risk of developing a mental illness. And again, this isn't rocket science to you guys. I just thought it'd just be good to get a snapshot of the populations that we know are at risk. So we know the risk of developing a mental illness is a result of a combination of individual, family, community and structural factors. We know that more specific to the individual, mental illness develops as a consequence of the interplay. So I call it biopsychosocial. So it's a combination of your biological, psychological and social factors. We know that there's certain populations that are more at risk of developing a mental illness. And the list up there is not exhaustive, but it's just some examples. So poverty, violence, disability, inequity, reduced access to supports, family history of mental illness, trauma, people that are exposed to substances in utero are more at risk. We also know with COVID, and this isn't rocket science to anybody, so mental health will become the pandemic post-COVID. We know that in the past with previous pandemics or previous disasters, it's the mental health that continues much, much later and continues on for a lot of people. So we know that we're getting a lot more people coming through with mental health because they've lost their jobs, because they've, their financial gains have decreased. The DV is on the rise. We know that is what happened, during COVID. So there's lots of risk factors that have become more to light while COVID has happened and it will continue.
What do you mean by DD, Kim? What do you mean by DD?
DV, domestic violence.
Clean my ears out.
So in summary, we can see the development of symptoms of mental illness is the complex dynamic between internal and external factors. And we know that mental health can bring about challenging behaviours, especially in the acute setting which we all work in. So I'll throw to Sue for challenging behaviours.
All right, so we all know that patients that come in to the emergency department, patients that we pick up on the road with the ambulance, they will at some stage present with behavioural disturbances. It's inevitable. Not all of them, but a lot of the people that we see, particularly people that are drug affected, people that have psychoses, and when they are aggressive, when they are agitated, it causes a lot of problems for us in the back of the ambulance, in the emergency department, in the wards, wherever we're working. So this section, I guess, is just about highlighting that. We know that. We know that we shouldn't have to put up with things like that. We know that, we have a no tolerance policy. But having said that, in the real world, we do need to manage and negotiate with the patients that we're seeing, and there are ways to be able to do that, and there are ways to be able to make it worse. And what we're trying to do is get the best outcome for that patient. If it's bringing them in via the ambulance and the police into the emergency department, we want to do that in the best way possible. We don't want to be confronting them or being angry with them. We want to be honest and we want to be transparent. And I know you all know this, but we're just going to run through a few basic things that we believe are helpful when we are dealing with agitated patients. I should be on this side. I can't even see that side.
She's got poor eyesight as well as ears.
There we go. So obviously any situation can act as a trigger for challenging behaviour. They're often unpredictable, as we know, and the most important thing is the approach to the person. I promised I wouldn't pick on you. Leave me alone, I don't want to be here. Get lost. How does that make you feel when someone does that to you? What's the first instinct when someone shouts at you or does something aggressive towards you as a healthcare worker? What's your instinct? Hands up, get back. What else? What is it? How does that make you feel? Really anxious, yeah. And then we say, keep calm, don't we? Keep calm, be patient.
Stop yelling at me.
How do you do that? You stop yelling at me. It's really tricky, isn't it? And yet it happens a lot of the time in the emergency department, in the back of the van. So what do we do about that? So we take a step back, we pause, we be patient, if we can. We speak slowly, we speak in a calm voice. There's no point saying, you need to get in the back of the van. I've got we're really busy at the moment, we've got lots of calls to do, we haven't got time to do this, or get in the back of the van, we're just going to get you to hospital because that's the ultimate goal at that point in time.
Or if you don't behave, then I'll call security. I mean, how confronting is that? We're in a distressed, agitated state, something's really upsetting us, and we get told if we don't conform to somebody else's view, then we're going to get manhandled, we're going to be restrained, sedated, and that suboptimal treatment often of seclusion, where we're then shoved in an environment where we're distressed, agitated, we're psychotic, we're dealing with lots of our own fears, and we're shoved in a room on our own and the door's locked. Scary.
Another thing that most of us as health professionals are really good at is explaining what we're doing. Explain the BSL. You're in the lounge room, explain what you're going to do. We just want to check your sugars. If it's not needed, don't do it. If they don't want their blood pressure taken, don't do it, but offer it to them. Can I please take your blood pressure? We just want to use that as a baseline and see where you're at the moment. No, bugger off. Okay, that's fine. We want to work with you. We want to try and get the best outcome for you. So I'm not going to prick you with my BSL stick. I'm not going to put my pulsometer on you and look at your stats. I don't really care about that unless we're really concerned about an emergency. And that makes sense. We all have our rules, we all have the things that we have to do, but sometimes we need to think about outside the square. Do we really need to get all the vital signs before they come into hospital if they're not medically compromised? If it's going to prevent aggression, if it's going to prevent someone being agitated, if it's going to lower someone's anxiety. What do you guys think? Yeah?
You all
Reasonable?
agree? Yep, lots of nods. Yep. I think some people often don't agree, and that's what we often witness, and we then have to step in to say, you don't need to do that. Step back from the patient. We can look at that and get to that when we need to.
And the other thing is, like making them feel more comfortable, respecting their dignity. I've always taught the students that I've worked with about unconditional positive regard, and I know it's a bit of a clang saying, but it's really about treating all the people that you have contact with unconditional positive regard, and that actually means treating everybody the same. I'll treat Quentin the same way as I treat Andrew, or I treat Kim, or I treat my partner. It's, and it stands you in good stead in life, and it's a really good thing to reflect on. It's hard to do sometimes when people are really annoying you, but just pull yourself back, reflect, and it's about giving that person the same respect that you gave the last person that was in the back of the ambulance, that you gave the last person that was in the triage bay.
Or I often even say, treat the person how you would like to be treated, or your family member. If that was your family member in distress and was being brought in, is that how you'd like them to be treated? So just trying to take a step back and think about what you'd like to happen to you, your loved ones, or somebody that you know.
Yep. And just keep them advised of what you're doing and why. What's going to happen now? Where are you taking me? Answer those questions. Be honest with them.
And I think that's the feedback we often get. And when we did the rapid response model, we would try and meet people within 5 minutes of arriving to an ED with a consultant, so we could map out their journey. And lots of that was about educating them about what was happening for them, because lots of them didn't know. The door was burst open, the police came in, I'm shoved in the back, I'm not allowed to go out for a cigarette, I have no idea what's happening to me. So trying to let them know, what's happening, why they've been brought in, and getting their viewpoint on that and listening to them.
Yep. Click away, Kim.
Oh, click too fast. There we go.
All right, so I've already talked about the art of communication. We know how to communicate with our patients. We know how to communicate with them when we're calm and we're relaxed. When we're not so calm and when we're like little duckies on the water and our little feet are pedaling because we're feeling intimidated or scared, it's really important still to try and be calm and relaxed and to avoid any harsh or abrupt statements. Avoiding words like, stop, don't do that, you mustn't, and you can't. Instead of, I can see that you're feeling frightened. I would like you to. Would you mind if? Or even, you're being a bit intimidating. Could I please ask that, that behaviour stops? I know it's tricky. It's really, really tricky, particularly if someone's really yelling at you, but it's amazing that if you can take a step back, be calm, and just use some of those things. I wanted to just quote a lady it's one of our clinical nurses in the emergency department, and she really has a hard time dealing with people that are intoxicated, particularly alcohol intoxication. And it was only a couple of months ago, and one of the gentlemen had come in through the ambulance ramp, and it's such an awful area at the Gold Coast Hospital. It's just chairs and ambulance and triage nurses and people running everywhere. And this poor guy's sitting there, and yes, he was intoxicated. He'd been really naughty, and he came in because he had suicidal thoughts. His wife had left him, he got drunk, and he wanted to kill himself. So what do? We pop him at the front door with all the excitement of things happening, and he got really cross. He wasn't allowed to have a cigarette. He wasn't allowed to finish his drink because it was taken off him. He wasn't allowed to make a phone call because his phone was left at home, and he didn't have any shoes. He was wet because he'd been found out in the rain, and so he was angry. All I want is a cup of coffee. And so this CN, who has the best heart, just stood over him and said, "How dare you? How dare you speak to my staff like that? We are not here to tolerate your nonsense. We're not here to be abused." And because of the way that communication occurred, we had what we call a code black. Security come, nurses come. So what could we have done differently there, do you think? I mean, I know it sounds really easy, but we get really busy, and we do get cross with people, and we cause emergencies to happen in our own emergency department or in the back of the paramedic van. What would we have done differently to get a better outcome? Giving him a coffee, giving him a rug, giving him a warm blanket. Just explain what's happening. You're going to be here a little while, sir. I'm sorry, but you're intoxicated. We can't actually do a full mental health assessment until you sober up a little bit. We want to make you comfortable. We want to get you out of the doorway, and we'll try and do that as soon as possible. So those simple things sound simple, but we forget them. I forget them. You know, you're rushing from here to there, but don't forget about the poor person that's really upset in front. Yeah? What have we got? Okay, so we pretty much covered this. How should I interact with someone who's becoming agitated? You know, I often like, what's your expectation of today? What would you like to see happen? Because then you're actually asking an open-ended question. You're sitting in a chair here. I have to wait for someone. I'm sitting in the back of the ambulance. What would you like to see happen now? You know, it's inevitable that we need to bring you to hospital because we're worried about your safety. But what would you like to see happen? And it's amazing.
That's about sharing the care with the patient then. It's not like a medical problem, you know, that we think the person's about to die. We need to ask them what is happening for them, what is it that they expect to get out of this or would like us to help them with.
Worst case scenario, we all know that we have the ability to offer sedation if needed. We don't like to use forced sedation, and that's only as a last resort. I know in Queensland we have the ability with the paramedics to use droperidol. I can't remember the last time I used that. You know, generally if we can talk people down and just explain to them what's happening, often the intoxicated, drug-affected ones, patients, I guess, are the ones that do present with the most difficulty. But even then, I think we've only used probably droperidol once in the last 4 months.
And I think when we look at our stats, the stats reflect that. So when we look at the ambulance stats before we came on with this other role that we can't talk about today, maybe next year, the stats reflect that the use of droperidol has definitely dropped since we have mental health clinicians going out with the ambulance and with police. Because we're more able to de-escalate on scene. We're more able to offer the use of oral medication once we get to the hospital, and we'll definitely carry that through. We've often have them in the back of the ambulance. We'll run in, speak to the consultant, get a verbal order. Once they're triaged, he's written it up, and sometimes we'll deliver that medication in the back of the ambulance and just let them settle a bit before we bring them in.
Yep. Okay, I think we've covered most of that, Kim.
Have you got the handouts? So we've got some handouts we're going to hand out to you, just something to take away. And again, there's not rocket science for you guys, but we just thought it's something to take away, and it's definitely something we teach our staff. Oh, there's a question, Sue.
That's funded by Queensland Health. So it's a collaboration between the Queensland Police Service, which is separate, the Queensland Ambulance Service and Queensland Health. So there's two arms to that.
Yes.
Sure did, yeah.
Yeah, yeah, and it's paying off. So when we put forward that business case study, and what the data is now showing is we're actually saving a fair whack of money to the health department. And I think we're also showing, and again it's for another talk, that collegial relationship where we're actually teaching police and paramedics that when, as I said before, when we're not on scene with them, they're actually able to follow through. So something that we just do, you know, when we're writing up is I'll often run through a mental state whilst I'm typing it with my paramedic. So then they're learning. So often then they'll then chip into what they think as well. And it's been a lovely progression to watch happen, I think.
We've even had to teach them. Sorry.
It's ongoing.
We've
Well,
had to teach them how to drive though, because you can't type on your keyboards while they're hooning. I'm just joking.
And look, and sometimes it is that collegial relationship. Sometimes we've had to drive the ambulance for the ambos if, you know, things go awry, or if we've been called to a medical, like, you know, as Sue said, it's only a small percentage of cases, but if we're the closest ambulance, we're it. You know, so I went to a drowning, significant drowning, more ambulances had to be called, the person had to be put on CPAP, so they went in another ambulance and I had to drive that ambo's ambulance back to the hospital and follow through. Same with the police, often had to drive their uncover police car behind an ambulance. If we need to put our police officer in the ambulance for safety, then we'll drive behind with the police vehicle in order to try and assist if things go awry in the van as well. So this is just some talk down tips, and we've given you all one of these to take away. And as I was saying, this is something that we try and teach all of our new staff, and definitely something that we try and promote on the ward. And again, you know, we're not trying to, you know, teach you something you don't know. It's just about refreshing these skills. Because as Sue said, when we get busy, we're all busy, we sometimes forget lots of these skills. And I even say it's good to have these in your personal life, even if you've got adolescents. I find this is good. And I often say to parents, you know, pick your battles with your adolescents, because if you're going to battle over everything, it's going to be a war zone at home. So did you want me to talk through those, or are you guys happy to read through them, or?
Yeah, we'll keep going, maybe do that and then the video. We've got two videos, haven't we, on?
Yeah. So basically the top is just, you know, how we control ourselves when we're faced with that scenario. The middle bit is just, you know, about how we look at it, clarify, resolve the issue. And the bottom feeds up, it's that respect and empathy to our patients. So we've just got a few YouTubes, and the first one I'm going to throw to my colleague down here. So this is an agitated patient in the ED. So I'd like you just to take note of what you think is happening, because we're going to ask you some questions.
Or not.
Technology.
You have to do it, Kim.
Okay.
Thoughts? What was happening for her? We might stop that one. What was happening for Rose? She was escalating, yeah. What do you think was happening? Do you think she was responding to any internal stimuli at all? Yeah, she was pretty scared, hey? Really hard to communicate with people like that, particularly when you're coming at them with things. Come on, we just want to do your temperature. Who just said that? Do we need to do it? Probably not. Probably the most important thing would be helping this girl to reduce her psychosis and possibly offering her some medication. We may or may not need to provide a little bit of force with the medication, but leaving someone in that psychotic state is not nice. But it's also not nice pulling their dignity away from them by enforcing things that don't need to happen. So I guess we're just reinforcing that a little bit in the room so that we don't do things that we don't need to do that upset people. This is a classic young lady that would come into ED who's psychotic, would come in regularly, sometimes using drugs as well. And it's very anxiety-provoking and intimidating for her to be in that environment.
Yep. The other one would just show, and it's American, but it shows you the pre and post. Again, so if we can just play that one just briefly.
Yeah, this young lady has an intellectual disability.
And these is often scenarios that get referred to us straight up.
Before we were using Monday.com or Teams around work. Our days used to split between work and managing work, but Monday.com.
Forget that one.
What was that all about, man? We good? So I need you to answer some of these questions, the police brought you here, and you basically have to answer some questions, otherwise you can't leave. I want to leave. So let's get this clear. You're not allowed to leave until we talk a little bit here, okay? I want to leave! Victor, settle down, okay? Do you hear me? I want to leave, please! I just want to go in! You need to settle down right now, okay? Otherwise I'm going to have to call security. I want to go home! Victor, settle down. I want to go home! Security.
Let's try that again.
Victor and Dr. Lee, what's going on? I heard you were upset you were shouting on a streetcar or something like that? Want to tell me about that? What was that, Victor? I want to leave! Okay, all right. I can see you're a little upset. Okay. All right. Why do you want to leave, Victor? What's the matter? My head hurts. All right. Okay. All right. Well, I'm a doctor. Maybe I can help you with the fact that your head's hurting. Okay. I know you got very upset before on the streetcar, right? I can see you're trying to stay calm now. Hey, look, you're doing a good job, okay? I understand you're getting a little upset, you're afraid. But we're going to try and help you, okay? We're here, the hospital, we're here to try and help you, okay? We're going to try and do our best. All right, so why don't you tell me about your head? What's going on now? It's at the back. Did you fall? Did anybody hit you? No, just boom. No, thing. I can't even explain it. Yeah. And is that why you started screaming on the streetcar? Okay. Yeah, I'm really sorry about that. I really apologize. I'm usually not like that. That's very nice of you to say that. Okay, it's all right. I'm glad everything worked out okay. Is there anybody with you, Victor? Is there anybody I should be calling? Yes, my sister. All right, okay. Great, I'm going to try and get your phone number.
And as I said before, they're often ones that are referred to us straight up, in the ED. So when you take a look at that, it's not mental health at all. But often because the person is expressing a lot of anger, a lot of agitation, then they just get labelled as mental health, and mental health need to do something. But when you can clearly see, if you can take the time and do the strategies, then you can reflect that it's actually a medical condition, and he's obviously got an intellectual disability, and we need to bring some family in to try and explain things further.
Isn't it nice to see two different scenarios with two completely different outcomes? Nothing was any different for Victor, but the difference was how we approached him, and we were actually listening and trying to understand what his expectation was, what was happening for him, and it was actually his really sore head that was causing him to be screaming out in the community, which brought him in the first place. So that's about that calm, patient, expectations. What would you like to see happen? How can we help you? Rather than getting upset with him, standing over him and calling security.
The next slide, and again, there's often conditions that are risk factors for aggression and agitated behaviour. And this is only just to note a few. So we've got psychosis or mood disorders, personality disorders, dementia, definitely substance abuse, drug-induced psychosis and intoxication, delirium, delirium in the elderly, and patients who have an infection. We definitely know that the other conditions that can cause agitation and aggression include the anxiety or mood disorders such as depression or bipolar. Sue mentioned before about the man that was intoxicated and was suicidal after his wife left him. He was intoxicated. Often once that intoxication settles down, there's really not much in the way of mental health left over. So often we'll really push that we really want to try and settle down the intoxication and then determine if there's a mental health disorder there that needs us to look at. Conditions that cause hormonal imbalances, hypothyroidism. I've talked about alcohol, autism, intellectual disability, as with young Victor, neurological disorders, and in rare cases, some brain tumours. So we'll move on to acute psychosis, I think, for a little bit, because I'm just aware of the time, and we could talk for hours on mental health, but we're trying to condense it. So I think we'll move on to a little bit about psychosis now, if that's okay with everybody.
Does anyone need to stand up for a minute, turn around, move your legs, do a squat? No? Sure? Okay. All right, so we just wanted to touch briefly acute psychosis, because often this is one of the causes of challenging behaviours and agitation, and can be a cause of aggression within the department or within the community setting. So as we know, psychosis is characterised by disorganised, confused thinking, can also be characterised by delusions, which are false fixed fears or beliefs, so it doesn't matter how much we argue about them, they're still going to stay there. And hallucinations, often auditory, particularly in people with a psychotic illness or something like schizophrenia. And more often we're seeing more visual and tactile hallucinations, particularly in the community, when we're first picking up people, particularly with drug and alcohol or organic causes. It's very rare that we see someone that has a diagnosis of schizophrenia that has tactile hallucinations. We often see it as well with the methamphetamine hallucinosis, or with the methamphetamine drug-induced psychosis as well. So as we just explained, it's accompanied by behavioural changes and agitation, and sometimes that's not really in sync with what we're seeing or with their mental illness or their mental illness diagnosis. Sometimes it can be something else, and there can be other factors involved in what's causing the distress. So I guess the challenge is for the paramedics, for allied health staff, for ED staff in particular, to find out what is it? Is the chicken or the egg? This person's behaving oddly, but what's it due to? And there are multiple medical conditions that present as mental illness. And sometimes we put these people in a little slot. We send them to our PEC unit, we send them to the mental health pod or the mental health area, and things can get overlooked. So we're just going to do a brief scenario and try and get as much interaction from you guys as we can. You just need to go back one, Kim, I think.
There we go.
All right, so this is a case presentation. This is a 25-year-old female who was brought in by the police and the ambulance. She was found in a petrol station. She was behaving very oddly. She was talking to herself. The patient had no ID, and how often does that happen? Lots? Yeah, a few nods. behaving bizarrely, talking to herself. No medical history was available either, and there was no one around to provide that. She was responding to internal stimuli. She was responding to questions with really inappropriate laughter, illogical statements such as, "Look, I'm a bird, I'm a queen, Jesus, leave me alone," and not making any eye contact. She's noted to be paranoid, repeatedly looking at the air vent. She was initially calm, but then she became violent. She became paranoid, and she started looking at things around her. We were trying to make attempts to establish communication, but that was unsuccessful. Redirection was really difficult as well. So she actually was one of the ladies that we were talking about that received some droperidol some months ago, because her situation was to the point where she was putting herself at risk in the community. She was also putting the staff, the ambulance staff, at risk as well. So she was restrained gently with the police, and also we gave her some droperidol. So her vital signs were then taken, because we had no hope of doing that prior to her calming down. Her initial vital signs, her temp was 38.4, her heart rate was 120, BP was normal, 110 on 75, and her respiratory rate was 24 per minute, and SATs were fine. So after she was transported to the ED, she was given some fluids, and then an hour later, she was sleeping. All her vital signs were back to being stable again. So a few hours later, the patient wakes up. She's slightly calmer, but she's now perseverating, saying the same thing over and over and over again. And she's talking about being pursued by a dark organisation which can read her mind and wants to cast her into a pornographic video. Imagine how horrific that would be to have that kind of a delusion. We're pretty crappy, I think. She was talking about, she insisted that the technician assigned to the ED, what we call the PSO or the orderly, was a particular agent of evil, and really frightened her when he came into the room. She refused any further vital signs. She refused any oral medication. And when she was asked if she was pregnant as a routine question, she lowered her voice and said, "That's why we're here. They're after me. Help me, please." She refused to provide any further history from that point on, and then she just became mute. What do you think the management would involve of this poor young girl? Sorry? Antipsychotics, yep. Yep. What sort, do you know? Yep. What else? What can we do to settle this lady down? Benzos, yep. Yep. Yeah. Yep. And things like lorazepam are often a good choice as well, because they're a lot shorter acting than the diazepam as well. And we can always give that IV and IM, whereas we don't like to do the old diaz IM, hey. It hurts. Change the environment? Where would you put her? Yeah, make her feel safe. So however you can, it might just be a matter of removing the orderly, because it's not going to continue to make her feel safe. Maybe turning the lights down, maybe giving her a warm blanket. You know, I used to work in a hospital where we had sensory blankets. We don't actually have them on the Gold Coast, but they were amazing. You could actually get warm ones as well, and sometimes people like that, you know, that extra pressure on them, or something that they can cuddle. You know, that's why a lot of people come in with their soft toys and things like that. What else should we be doing?
I think if we have history too, if we know the people, then often there's plans, and we know what has worked in the past. So that's really important to try and look back at past notes if they've been in before as to what we've done. Yep. Sometimes when they come in unidentifiable, then there's some ways, like often people will ring me and go, "Can you walk past this person? They're acting strangely. Do you know them?" I go, "Oh, yep, that's such and such." You know, because we have our regulars that might be found with no identification. But because we're out with the ambulance, out with police and in the ED, we often know lots of our regulars or lots of people on the Gold Coast.
Yep. You call them frequent flyers? So people that come in regularly? Yeah. So you might have a plan for them? Yeah, yeah. 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 So we're just talking about people that are not so readily identified if they haven't got any ID on them, keeping a bit of a record if we do know them, asking other staff, keeping a plan with a patient's photo with their consent, obviously, so that when they do come in, we've actually got a bit of an action plan.
I mean, we have a regular that is often on the Sundale Bridge. As soon as we hear, adolescent on the Sundale Bridge, we know who it is. So we go, we'll go to that one, because we can actually engage him and talk him down. I have to be close to this thing. Yeah.
So what do you think the differential diagnosis could be? Drug-induced psychosis? Schizophrenia, yep. She could have an encephalitis, yes. Substance abuse, yep. Yep, so at the back wants to know, is she pregnant, and is that why she's not taking her antipsychotics? Is it because of non-adherence to medication? Yep, good point. Bipolar? Yep. Do you often encounter people with bipolar disorder with auditory hallucinations? Very rare, but possible. Yep. Yep. Okay, let's have a look at some other possible causes. We're looking at hypoglycemia. People can become quite confused when their blood sugars get too low. Drug or alcohol, intoxication and withdrawal. We've talked about substance abuse, psychosis, and thinking about amphetamines, particularly in today's day and age. I know we get a lot of methamphetamine abuse on the Gold Coast. Synthetic cannabinoids are just lethal at the moment. Infection, systemic, central nervous system, encephalitis, very good, which was picked up here, or some sort of a sepsis. We shouldn't always just go to mental illness. Intracranial bleeding, possible, if there's any evidence of trauma, which there wasn't in this case. Hypothermia, probably not possible with the temp of 38. Hyperkalemia, unlikely. Her SATs were sitting at 98. Vitamin deficiencies, like something like Wernicke's, and possibly thyrotoxicosis. So there's a stream of differential diagnosis, and you guys have picked a lot of them up.
So we might rush through this because I'm aware of time. So everybody knows our history-taking hints. I mean, you all do it. So if everybody wants me to skip through that one, I think there's nothing new in that. And this leads into my big bugbear. The diagnostic overshadowing in mental health.
Kim's the queen of diagnostic overshadowing.
It's my biggest bugbear for our mental health patients. I mean, how many times do mental health patients come in, or people come in and they've got a mental health history and it's streamed straight towards mental health? A lot. All the time. And my big bugbear is that we often miss lots of things because anybody just sees a history of mental illness and bang, they need a mental health referral. And we actually miss so much. And I think as clinicians, we need to be really aware of this and take note of what else could be happening for the person, or what could be the comorbid medical conditions that the person may have. Back way in the day, I used to specialise in addiction psychiatry. I used to see it all the time with my patients then too. They'd turn up to go to a GP, they'd be turned away. Lots of them had significant dental problems that were causing infection, cardiac issues. Nobody would see them just because they had a history of, benzodependency or drug-seeking behaviour. So lots of them, nobody looked at what their comorbid medical conditions could be. So this is the one thing that when I'm on shift as a CNC and AD, I really try to look at. I mean, if it's really clear it's mental health, it's mental health. Happy to work alongside the medical team whilst they're doing what they do and do the mental health assessment. I don't wait for medical clearance if I think it's straightforward. But if I think there's any touch of any medical thing going on, then I will push back a little bit and just ask for some further diagnostic testing. And I think that's one thing I want you guys to take away is just if somebody comes in or you pick somebody up, just be aware it's not always just mental health. And even if it is mental health, what else is happening for this person? You know, why should they not receive the same treatment that anybody else would receive in the emergency department setting?
Okay, so we're just going to touch briefly on treatment options. Particularly with this young lady, you know, we look at initial stabilisation of the person, which we've done. We've provided some fluids, we've done their OBS, we've helped settle them, we've given some pharmacological medication. We've mentioned benzos, which are really good for the acutely agitated patient. You know, we're looking at the drug of choice probably being a lorazepam or midazolam, because as we said, we can either give that IV or IM. Antipsychotics are useful, particularly olanzapine, just to really help settle, to get that person out of that acute psychosis, because as we know, the longer people stay psychotic, the harder it is for them to recover.
And even our drug-induced, I mean, it's my big bugbear, I get straight out the front, and 10 and 10. If we think it's intoxication, let's just manage the intoxication and see what's left. Because half the time we manage that, they have a bit of a sleep, they wake up and bang, psychotic symptoms are gone. Physical investigations, you guys all know. And as I said before, sometimes we'll really push back if we think there's something more happening. Other times, if it's one of our clients, you know, happy to go straight on and do what we need to do with the client in ED.
Okay, we look at the disposition of our decisions. What do we do with these people? What do we do with this poor 25-year-old lady? So, one of the options is obviously admission to hospital medical assessment unit, medical treatment unit, depending on whether the causation of the agitation psychosis obviously has been an organic cause. The other decision is, can they go home? Can they be successfully transported home with support from the community teams? It depends, every state is set up differently. We would certainly look to get some assistance from our acute care team who can visit them regularly or do telehealth with them. This may or may not be successful depending on the causation of the psychosis. And then obviously we've also got the decision whether we want to admit to the mental health facility. Any questions out of that so far, guys? I think we've got about 10 minutes left, Quint. Yeah? Look like we're running on time. That's amazing.
Amazing for us anyway. So the next one, we really want to touch on borderline personality disorder, because it was something that came up last time when we spoke, and it's something that everybody struggles with, is your borderline personality disorder client that attends ED. And I suppose our new role is that we get to see these patients outside in the community and we can prevent them coming in, because we all know that often bringing them to ED is the worst case scenario for that person, and we definitely always try not to admit that patient to a ward, because again it's just reinforcing lots of those behaviours. But I also hear even my own staff talk about, I'll just give them a therapeutic wait. Does that work? No. If I was distressed and agitated and you left me sitting there for hours just because you didn't like my behaviour, what am I going to do? I'm going to arc up more. You know, and I always say to my staff, they're not coming here today to piss you off. They're not going, you know what, today I'm going to go to ED and piss off that triage nurse, because that will make me happy. You know, they're obviously not managing something in their life, and it comes out in all sorts of different ways.
And these guys are the guys that push our buttons the most, aren't they? They might take a razor blade to the toilet and do a little cut there. They might try and grab the IV cord or something and try and wrap that around their neck. They push our buttons. They don't do it intentionally. They're not trying to annoy us. It's about their issues at the particular time, and that's how they can actually display their emotions. So difficult.
Quick slide that we can show that a bit of a YouTube that will sum it up rather than me talking through all this, but I suppose Sue hit it on the head. It's that transference and counter-transference. And even our own mental health staff get it. You know, even at times we get it. You know, we've had a shitty day. We've, you know, back to back with this type of behaviour, but it goes back to those techniques we spoke about earlier. So taking that step back, calming ourselves and looking at what we can do to manage the situation a bit better.
And that art of reflection, we can't underestimate. You know, we talk about transference and counter-transference, and if you've probably heard of those terms, but you know, you might see a lovely little lady sitting at the triage area. It reminds you of your grandmother. And so you walk up to her and, hello, would you like a cup of tea? How you going, darling? Because we can identify, and it's not a conscious thing, it's something that comes from our subconscious. Or I might be that clinical nurse whose father is actually an alcoholic who gave her a hard time when she was a young child, and she often saw domestic violence. So she stands over the patient and says, how dare you speak to my staff like that? You're a drunk. So, you know, that's transference to the things that we're feeling, and it's really important to be aware of that. And that reflection, possibly not at that particular time, but that reflection even at the end of the shift is really important so that you can actually center yourself again and go, well, maybe I didn't handle that so well, because none of us are perfect. And we're all affected by other people's emotions. But being able to reflect on that and using some of that emotional intelligence, how your behaviour affects other people and how other people affect you, is going to stand you in really good stead.
And I think it's important to remember, if you do have some counter-transference towards somebody, seeing if somebody else can actually do that assessment on that person. Ideally, sometimes it can't, and I think that's when I try and take a step back and take a deep breath and go, I've got to step into it. I'll give a quick example. My father's recently died 3 weeks ago. So anybody that was coming in that was, you know, had issues to do with death, I said, please do not ask me to go and see, because I wouldn't have been able to hold it together to be able to do that assessment. So it's about acknowledging those trigger points in yourself and asking somebody else to do it. And nobody's going to, you know, have a go at you if you acknowledge why you can't do it at that point.
And as a paramedic, get your partner to do it. You can always interchange, hey?
So we'll just put on that last video that will sum up BPD for you. I'm not doing very well with this clicker. And we're on time, Quentin. Dylan, yay.
So fat. Brendan, you're not fat. It's a shirt. What do you need?
Oops-a-day.
It's estimated that at least 1 in 100 people have borderline personality disorder, or BPD. In this video, we'll talk about what it's like to have the disorder, as well as how people can recover from it. Here are some of the issues people with BPD face. Significant difficulty controlling and regulating emotions, otherwise known as emotional lability. Uncertainty of self, what psychiatrists call an unstable self-image. Having intense and unstable relationships repeatedly, which can involve idealizing people, then intensely disliking or devaluing them in relatively short intervals. Feeling an urgent need to avoid being abandoned by other people, even if the abandonment is only imagined. A chronic feeling of emptiness, repeatedly acting in impulsive and risky ways. As you can see, it's a picture of instability. To add to these challenges, BPD is currently under-recognised, so the availability of specific services is limited. The reason may include the ongoing social stigma of mental health conditions, or the challenges that health professionals face in treating BPD. It is quite possible to treat, but more on that later.
We might have to stop it because I'm just aware of time. How much time have we got left?
Something about your new partner.
Got 5 minutes.
May react ferocious.
Yeah. I mean, that YouTube is on our slide, so if you do want to look it up later, it really does describe what BPD is. And as Sue said, it's, you know, it's the common theme that we get as paramedics and in the ED environment. You know, and I think it's often very sad that lots of these people, the only type of connection they have often to people is to come to an ED. I mean, how sad would that be that, you know, your only connection to feel nurtured is to come to a hospital, you know? And I think if we can reflect on that and try and look at how we can help the person in that way. Questions with a bintang. We had a bintang, we'd give you one.
Before bintang.
Instead of the brains, we maybe should have handed out a bintang at the end. Any questions? Yep.
In our hospital, the top DRG, which is diagnosed really group, no, thank you very much, is mental health.
Yeah.
because you are under the pump from no beds, ambulance need to get back on the road, people are not very pleasant to one another. And it's just a vicious cycle. And it's awful, but I do know that mental health clients are treated like second class citizens. Someone with abdo pain gets put in a bed. And
Yep.
they come back and get that.
Can everyone hear what was just spoken about? It was just talking about the backlog in the emergency department of that particular hospital. I don't think it's particular to your hospital, but very, very busy. They get treated like second-class citizens. They get put in a chair with everybody else. And if you've got abdo pain or if you've got appendicitis, you'll get a bed. If you've got a mental health supposed diagnosis, you may not get a bed. Very, very difficult, and that's just about helping people to change their attitudes, and we do it one bit at a time. We can't change the world, we can't change the system that way, but I guess we can learn more about how we can actually help that person in that chair at that particular time. You might have a chance just to grab them a warm blanket, that might be enough. You might have an opportunity to stop someone yelling at them from across the way, position them in a different area, turn the light down a bit. We just do the things that we can do, and we understand the constraints of the hospital systems at the moment, we really do. But we hope that, the more that we have conferences like this, the more that we can actually push that message across, and there's another 80 of you now that can actually go and say, we've got to do something about this, we really do. I'm not sure what the answer is, but we really do need to provide more efficient and quality care for our people with mental illness.
And I think it's also about education. I know that if we look at triage scores, how many of our mental health patients get triaged 4 or 5? Do you know what I mean? If you come in suicidal, you shouldn't be a 4 or 5. Yes. Should be. Absolutely should be like that. If you get brought in by emergency services and you're at risk, then you should be a Cat 2. But often, it doesn't really happen. So I think it's just, as Sue said, looking at those strategies and also looking about the bigger picture. So that ongoing education, looking at, which is something that Sue and I, have been doing for years, about trying to push forward new models of care. We did that with the rapid response model. We've done it with ED avoidance strategies, working with paramedics to stop these people being brought in. But we don't have all the answers either, but we agree with you, it is a huge problem. Okay.
To bring our model of service to WA. You mean the QES co-responder? Is anyone from WA? Can you answer that one?
My last ambulance role in WA was in the southwest in Bunbury, and they are actually running a particular mental health ambulance out of Bunbury Station. It had a long gestation in terms of funding, but they have 2 mental health practitioners on that vehicle. They do get tasked to other roles, but they're funded for mental health jobs specifically.
And I would hope nearly every state can look at the data coming out from the states that are providing this service, because it does make a difference, especially for our mental health patients.
We also spoke to some nurses from Geraldton. Where's Denise and Leanne? You have a couple of, or a mental health nurse that actually goes out with the ambulance from Geraldton as well, don't you? With the police. And they'll attach to the police, they'll attach a mental health nurse. Well, that's a good beginning as well, isn't it?
I think it's maybe going back to your organisations and saying, look, there are different models out there. Is it worth looking at those models? We definitely have 2 of us on a shift with QAS and 1 with QPS on every given day. And we're trying to push that, to get more staff to do that, because we see that, there's a real need.
Look out, Quentin's getting the coat hanger out. Thank you guys for listening. I really appreciate your attending this afternoon.
No, thank you very much, Sue and Kim. We really appreciate you returning to Bali and gracing us all with your presence, and I think you're fantastic advocates for mental health in the acute setting. And if anyone does want to have a bit more of a chat to Sue and Kim, including ED avoidance strategies, they are hanging around, and I'm sure they'll be having a few drinks tonight, so good ones to sort of catch a hold of there. I also don't like single people out, but I'm going to do it now, and I think Kim just deserves an extra special thanks. She's had the year from hell and still is over here and is a shining, bubbly self. So let's hear it for Kim as well.
So I suppose what Quinton's referring to, my father did recently pass, which is probably better that he passed before I got here. But my partner also had a significant accident while I was on shift with QAS, significant motorbike accident. He actually should be dead or a quad. He's amazed everybody, but I had to stop my shift, go back into my trauma room and be the family member. So he's fractured C1, 2, 3, 4, 5 and 6. C4 and 5 are now fused. 10 fractured ribs, fractured ankle, a left occipital bleed and a frontal bleed. So he's here in a hard collar, but yeah, I think it's going to be a long road ahead. But yeah, so I couldn't miss Bali anyway.
Thanks, Kim. Let's grab a break, fill your plates up with food, and we'll get Polly started, as before, 5-10 minutes. Oh, sorry, and also there's certificates at the back. So if anyone hasn't picked up their certificate of attendance yet, please grab it from the back table. If you've got colleagues unable to be here today, feel free to grab it for them as well. Okay, let's give away some prizes. So once again, today we've got $100 from Everest Wealth for Rebel Sport voucher. We've also got 2 of our Rido Hero shirts. So I think there's only 6 submissions today. So 50% chance of winning a prize with your photos up there. Loudest cheer gets the prize. Let's kick it off with our first one. Oh, presenters, Kim and Sue on the rooftop bar. Do your drinks in? Whoa, what's going on there? Oh, that's a nice one, the lawn in Canggu. Scenery shots don't get many cheers, just for the next conference, a bit of a tip there. Oh, another presenter, Andy, what do you reckon? I think we've got our winner at the moment. Not sure if they're in the room today. Excellent. So I reckon we've got a clear winner. Yeah, definite winner, $100 Rebel Sports voucher. Then I reckon, yep, second. And then what do we reckon? Rooftop? All right, sorted. So anyone who's won a prize, please make your way down at the end of the session. Just a quick reminder, sorry I was an afterthought as we're all leaving for afternoon tea. We do have the certificates of attendance at the back. Please feel free to grab yours and your colleagues, if not in the room today, to take it back to them. And my final time I'm going to mention it, the lanyards for tonight. Lanyards mean you can walk on straight up the stairs, you won't get stopped, you won't get asked for your name. It's like access all areas. If you can remember to bring it, that would be great. If you've already lost yours, it's okay, it happens. Come see Dylan or myself, we can get a lanyard for you. If you get there tonight and realise that you've lost yours, once again, that's fine. We do have a list at the door. We're just trying to, I guess, expedite things so you can get drinking sooner. 7:30, Corner House. That's the final reminder. If you do need any help at all with directions, Dylan has posted a map up on the Facebook group, or just see one of us and we can just share our screenshots with you. I'd now like to welcome up our final presenter. He's flown in last night, he's fresh, and he's going to be closing the conference off with a great, I guess, mesh between nurses and paramedics and talking about utilising nurses on road here in Indonesia. So let's hear it for Dr. Suryanto.
Is this my turn now? Okay, good. All right. Thank you very much. Right. Good afternoon, everyone. So it is now my turn. Thank you very much for Quentin and also Dylan. So what is my presentation? Here we are. Right. Good. So first of all, I would like to thanks to the EMS Conferences Australia, especially to Quentin and Dylan for inviting me to be in here to share about my experience and a bit of knowledge in terms of nurses as prehospital care providers in Indonesia, lesson learned. So probably I'm the only one Indonesian in here, right? No? Oh, you are Indonesian, right? So most of you are coming from Australia, so welcome to Bali. If Bali is part of your second home, so welcome back to Bali, because some of you probably, most frequent to Bali compared to myself, even though I'm coming from Indonesia, but I'm actually coming from Malang, which is part of East Java, about like 10 hours driving. But about like 45 minutes flight from Surabaya to Bali, and then Surabaya to Malang, about like 2 hour driving. So before I start, this is a bit of my profiles. My name is Suryanto. Just call me Suryanto. I don't have any family name. So it's common for Indonesians that we don't have any family name. And it's become a story of myself that I went to Australia, then they want to know which, who is Suryanto is this? Is it like related with the kind of crime or anything? So they check me a lot of things before I come to Australia. And finally, I can come to Australia because I did my study at Monash University. Oh, sorry. at Monash University. I'm currently a lecturer at Department of Nursing, Faculty of Health Sciences, University of Brawijaya. And I have a nursing background, so I can see that from the previous presentation that half of you are probably nurses or health allied, and half of you are paramedics. So I have a major interest in pre-hospital care, emergency care, and ambulance services. So this is the thing that I'm going to discuss with you today, which is the pre-hospital care system in Indonesia and also the pre-hospital care providers in Indonesia. So in the first part, probably Craig Hooper already discussed on Wednesday, and Quentin told me that be quick on that one, so focusing more on the second part of my presentation. Okay, that's fine, yeah? Right, so move to the first part of this presentation, the pre-hospital care system in Indonesia. So, this is the thing, okay, sorry. Right, so in the case of emergency, I just want to make sure that Craig Hooper provide a good information to all of you. So, a bit of interaction between myself and all of you. So, now we all are in Bali. And in the case of emergency situation, where would you call? So I would like you to log in into the www.menti.com and use the code, yeah, 78375761. So could be access into your mobile phone, access to the menti.com and use the code 78375761. So if there is an emergency situation, where would you call? Just want to make sure that Craig Hooper provide good information to all of you. 112, right, good. Right, 911, right, good. 119, right? So most of you will dial 112, 119, right. Good, excellent, nice. Nice, right, good. Big round of applause to all of you, yeah? Okay, so the majority of you answered 112, right. Actually 112 is kind of like, you know, yes, it is like a call center for emergency situation in all around the world. But actually in Indonesia, we have our own call center for emergency situation, which is 119. Yeah. So yes, 112 can be accessed in everywhere in the world. But actually in Indonesia we have just like in Australia, you have 000, and then in here we have 119 for any emergency situation. Actually, this one is not. Before we have 119, we have 118 actually. So this is the story. Sorry, I'm not really good in this one. All right. So the 119 system in Indonesia, the EMS system in Indonesia, is just started about the April 2016. So we have 119 EMS system. We call in Indonesia is Sistem Penanggulangan Gawat Darurat Terpadu or Comprehensive System of Emergency Management. And it's just launched in 2016. Within this kind of system, we need to have like a two part of this kind of system, which is the NCC, the National Command Center in Jakarta, organized by the Ministry of Health, and also the Public Safety Center or PSC in each city of Indonesia, including in Denpasar in here. Right. So before 119, we have 118 emergency ambulance services around in the year 2000. But due to the financial issue, it has been, cannot be implemented anymore. So around 5 or 6 years only, yeah, the 118 emergency call system in Indonesia. But currently it's still available in Jakarta as part of the private ambulance providers, and also they also provide the emergency related training in Jakarta. Currently we have 119 emergency medical services started on July 2016, and during the launches on 2016, we only have 27 locations, yeah, in 14 out of 34 provinces. And the current situation, we have more than 500 cities in Indonesia. So this is the how the system works. So it's been like, overview how if you call 119, not 911, yeah, 911 is on America, but this one 119. So 111, if you call 119, it will come and goes to the NCC in Jakarta, and then from Jakarta, it will be goes to the province or in the district or the area, which is coming from here, like going to Denpasar. But this one's is the by regulation. Some of the cities, if you call the 119, do not goes to the NCC, but directly goes to the city or district where you're calling. So this good innovation, not innovation actually, good shortcut, not going to Jakarta, but directly goes to the call taker or call center close to the area where you call. And then the dispatcher will dispatch the ambulance to the area where you have an accident or emergency. Right. So this is the NCC, yeah, in Jakarta. So there are call takers, and I also have like a chance to visit the NCC with staff from Monash University, going there to see how the system works. And then this one, the PSC. This one is in Jakarta. They provide, so it's kind of like different how the EMS system in Australia and Indonesia. The EMS system in Australia focusing only on pre-hospital care, but in Indonesia we also provide in-hospital care as well, especially when the people calling, is there any like, bed available in that certain hospital or not, they also can provide that kind of information, especially in Jakarta. And also they also provide the inter-hospital, where there's like a referral needed, so they also can provide the referral transportation for the patient from hospital A to hospital B, for example. So this is the other PSC in other outside Jakarta. Some of them are good, some of them are not really good actually. And so this is the development of the PSC itself. So start from the beginning in 2016, only 27 PSC in Indonesia. And then it's going up until 2022, 279 PSC in Indonesia. Actually, by regulation, every single area of Indonesia must establish the PSC within 2 years after the regulation. So it means that by July 2018, all 415 area in Indonesia must have PSC. However, until now, this year, July this year, only about like 45% of it has PSC. So this is the situation where there is no PSC in Indonesia. So if they have like good PSC, they will have a good ambulance for sure. They have like fully equipped, just like not really, compared to Australia for sure. You are the best, better to Indonesia for sure, But in here we try to be, to have like a good ambulance vehicles as well. This one is Jakarta, and this one is my area. One of the example of ambulance. We have like full equipped, just like a mobile defibrillator, like ECG monitor, that kind of things. But some of the part of Indonesia, which is do not have any PSC, or maybe they have not really, have like a financial support how to establish a good ambulance, they feel lonely, just like this one. Only have like a tank of oxygens, and I'm not sure whether it's there's an oxygen inside or not. Because some of them it's there is no oxygen inside it. So sadly. So, and also a place, water basin to wash your hand, and that's it. That's the real situation. Especially in ambulance of the puskesmas. We call this puskesmas called like community health services, because there are two main health facilities in Indonesia, the hospitals and the puskesmas. The puskesmas is community health center. So most of the puskesmas has this kind of ambulance, which is not really well equipped. So, in implementing the PSC in the EMS system, there is one big issue. Too many variation how to access that kind of system. So for example, this is just an example of 3PSC in Indonesia, how they can access the ambulance services in that area. So a lot of variations. They can call directly in 119, yes, but some area it costs a lot for them, yeah, because it's like about like 100 million rupiah for Indonesia, and some area it is quite expensive for them to organize the 119 system. Therefore, some of them have like a mobile phone for the access, and then a landline for the access, and also mobile application. So a lot of variations. This is one big issue. And if we see like, you know, how Australia call the ambulance or any emergency situation, just 000. Every states you have one number which is 000. In here, if you go, for example, like to Malang, you have to make sure which number I can call during the emergency. And if you go to another state or a province, you have to know which number you can call. So it's quite, a big issue why there is so many variation. It should be one call center which is 119. So one of the issue in Indonesia is this one. So that's how the system works in Indonesia, especially, so now move to the second part of my presentation, which is focusing on pre-hospital care providers in Indonesia. So this is the comparison between like Australia, the developed country, and Indonesia. So in Australia, for sure, half of you are paramedics, so you have your specific professionals working on ambulance, which is paramedics, yeah? In other countries, such as America or maybe Singapore or maybe Malaysia, they have EMT, the emergency medical technicians, which is provide pre-hospital care, and they are not nurses, they are not doctors, you are paramedics. But Indonesia, nurses are staff in the ambulance. We don't have any paramedics, we don't have any EMT. And like you guys in Australia, there are levelings, career pathways for those health providers working on ambulance. But in here in Indonesia, yes, we have career pathways for nurses, but working in hospital. Even though we have that kind of regulations, it's not really well implemented. Some of the hospital can, implement that kind of regulation, the career pathways, but the majority of the hospital unable to, implement that kind of system. This is because, yes, there is a regulation, but there is no, compulsory for each hospital to, implement that kind of system. So it's kind of like, ambiguity for the healthcare facilities, whether they will, 100% implemented that kind of system, the career pathways, or not. That's for nurses working in hospital. For nurses working in ambulance, it's getting worse. Yeah, there is no regulation on it. There is no, what kind of skills, what kind of, intervention that you can do when you are nurses working in ambulance. We don't have that kind of rules in here in Indonesia. So this is human resources pre-hospital in developed country, just like you guys in here. You have paramedics, just like in Victoria. There are two levels, the LS paramedics and also the MICA paramedics. In other countries, just like US or Singapore, they have EMT, advanced EMT or paramedics with different types of name or leveling. But yes, you guys and also the other countries have the leveling. But what about Indonesia? No. We don't have that kind of leveling. So there is no paramedic profession in Indonesia, and currently, mostly are emergency nurses working on ambulances. All right. So, however, there is no formal education. Oh my goodness. It's kind of like, I can't cooperate with this one. So, please be good to me. Right. So, be patient, Suryanto. Right. See. All right, good. So, however, there is no formal educations, for nurses working in ambulance. And also, there is no course, like informal training or that kind of things for nurses working in ambulance. There is no such kind of things. So, This is the picture of nurses working on ambulance based on Puskesmas, the community health services, and this one is the picture of the nurses working on ambulance based on hospitals. Like I say, there are two major health facilities, the community health services, the Puskesmas, and also the hospital. This is my supervisors and also his colleagues, Jamie and also Malcolm Boyles, currently working at the Griffith University in Queensland. So both of them coming to Malang, to my area, and see what is actually the EMS system working in my area. So based on regulations, actually there are, all right. So based on regulation, the Ministry of Regulation, there are human resources needed in PSC. Yeah, the call center operator, the medical human resources, and the coordinators. It seems like simple, right? So just not like in Australia that maybe you have like a medical directors, you have like dispatcher, you have call takers, and a lot of paramedics working on ambulance. But in here, the medical human resources, there are three professionals: the doctors, nurses, and midwives. The current situation, most of the PSC are run by the nurses. Doctors, yes, some of the PSC they become the medical directors, but some of them only have like on-call services, not really working on PSC, because sometimes the doctors also working in other place, just like in hospital or maybe in community health services, so they're not really full-time in the PSC. So the nurses are working mostly working on ambulance are nurses. Midwives, some of them, yeah, but as you know that midwives have like a limited skills and also limited intervention can be done in the pre-hospital care. So the midwives, some of the PSC, yes, there's midwives in the PSC, but not really, not much they can do on pre-hospital care. So let's back to Menti, yeah. Excuse me. Back to Menti, yep. So based on that kind of situations that nurses are working in pre-hospital care in Indonesia. So I want you to go to the menti.com again, yeah, the second slide. Right. So in your opinions, what are the challenges for nurses working on ambulance? In your best expertise that in Australia, paramedics is paramedics, they're not nurses. They're working on ambulance. But in here in Indonesia, nurses working on ambulance. As you know that nurses and paramedics, yes, we are healthcare providers, but we have like a different perspective. No, right, the challenges are training, fear, skill set, time dynamic, right, good. Under skill autonomy, no guidelines. Equipment, great. Lack of pre-hospital care. Nice, I like this one. Right, uncontrolled setting, educations. Specifics, right. Nice, mobile environmental, yes, good. Nice, excellent. Right. So in here we can see that the training, education, skill sets are the most fear, right? Training is the most one, right? Thank you very much for all of you, yeah? Give a round of applause to all of you, yeah? Great, yeah? So in here we can see that training, educations is part of it. Yes, we do agree that one, yeah? So in here, lack of guidelines, yes, like I said before, there is no regulation on it. Reduce scope of practice. Generalist skills, no SOP, yeah, no operating standard, no training, yes, change of environment, professional regulation, right, good, yep. So in here we can see that there are four big issue in here: training, educations, skill set, and fear. Yes, I can see that. Yeah, working in ambulance are different. In here, nurses are trained, they are thought to be working as a nurses working on ambulance. When I first met with my supervisors in Australia, she asked me, why you are interested to study more on emergency nursing? I said to her that Well, because in Indonesia, working as a nurse in emergency is quite challenging. Why is that? Well, because patients coming to ED are unpredictable. It can be like, in a good condition, just like only a fever, because they don't want to go to the outpatient clinic, because the fastest way, they go to the emergency department. And then it also can be like the worst situation on patient, that crash accidents and blood everywhere, that kind of things. There is no treatment at all during the pre-hospital care, and bring direct to the hospital. It's quite challenging. And sometimes there is like a, mass casualty incident, just like 2 weeks ago or 3 weeks ago. Maybe you heard that the Kanjuruhan tragedy, the football tragedy. Yeah, it is in my area. And it's kind of like a slap for us that we don't have any good system. Yeah, we don't have any good system in how to manage the mass casualty incidents. And it's become like, when we realized, it's kind of like a good lesson for us, that if we want to have a good how to manage the mass casualty incidents, we have to be good in our daily practice in emergency care, especially in pre-hospital care. And as you can see that not all area have the BSC, not all area have the system, how the pre-hospital care works in that kind of area. In Malang, in my area, where the Kanjuruhan, the football tragedy is happening, we have that kind of system actually, the daily one, but it's not really good. Yeah, I can say that, sorry to say that. It's kind of like, the bad of myself, I told to you. But this is the real situation, that in daily emergency, we are not really good. Some of us, for example, in Malang area, there are 3 regions, which is the Malang City, Regency, and also Batu. The Kanjuruhan tragedy happening in Malang Regency. The Malang Regency itself, the system of EMS system, how the ambulance services can be accessed is using that kind of system, like, using 119, yes you can, mobile phone, yes you can, the application, yes you can. But then the ambulance services is not available in that kind of like, we call it like ambulance station. No, they also then the ambulance vehicles available in the community health services. So if there is an emergency situation close to that kind of community health services, the dispatcher will call, hey you, there's an accident close to you, please come to the site of the area. So that kind of the system. And during that event, it's kind of like, we are probably what is called in English, we are underestimated about the situations, because that kind of football match, there is no supporter from the other sides. So the supporters only coming from our sides, which is there's not really, high risk to be like, incident or chaos or anything, because there is no the supporter from the other sides. But because of that underestimate, maybe, the system itself not really good, how they can, prepare for the mass casualty incidents. And that's the situation. About like 131 people died during that kind of tragedy. It's kind of a slap for us. Just like similar with how the tsunami. The tsunami is also a big slap for us, for Indonesian, that during that time there is we don't have any preparation how to deal with the disasters. And after the tsunami, we are preparing more and more and more, even though now we still, how to organize better and better, but still there's a lack of something in anything, because Indonesia is quite wide compared to Australia. We have like more than 250 peoples, and then not all of us are well educated, so it's quite hard to manage all the Indonesian into one voice into one regulation can be applied in all Indonesia. It's quite hard, so that's why there are a lot of things that we need to improve, and by the end of this presentation, I need you to give back, like, yes, the title is lesson learned. Maybe you can learn something from me, but also by the end of the presentation, I also need I need to learn from you guys. By the end of the presentation, there is like a discussion at the end of this presentation. So so back to your comment on the mentee, that we need education, we need training on how nurses working on ambulance. Yes, correct. The first question is, are nursing graduates in Indonesia well prepared to be working in ambulance? This is the main question, just like what you are thinking, that training and education is the two challenges, the biggest two challenges if we want nurses working in ambulance in a good way. So this is based on my PhD thesis. I did the cross-sectional study consisting of paper survey. I involved 394 new bachelor nursing graduates from nursing institution in Malang. Using questionnaire, I investigated whether are they ready to work on ambulance. Just like I said before, that nursing students in here, we teach them how to work in hospital, not in pre-hospital setting. Some of you also mentioned about different setting, different environmental. Yes, I do agree with that one. So this is the result of my study, that there are 8 elements of working readiness to be ambulance. And there are theoretical knowledge, clinical skills, practical skills, interpersonal skills, communications, coping skills, lifelong learning, and also ethics and legal responsibility. In here we can see that the lowest scores coming from these 8 domains of work readiness to be ambulance nurses are coming from the practical skills. Because like you said, there's like a different environmental. Like, you know, working in hospital different when they're working on ambulance. It's huge different. That's why most of the nursing graduates, the new one, lack of practical skills. The best one is coming from the ethic and legal responsibility, because I think nurses and paramedics working in the same things in terms of ethics and responsibility. This is the thing that we need to figure out, yeah, how to improve their practical skills. And the second is related with the theoretical knowledge. They don't have any good knowledge in how to providing care in ambulance services among those nursing graduates. So this is the thing that we need to improve in Indonesia. And right, and those are coming from the nursing graduates. And now move to the nurses who already work on ambulance. I did an investigation as well, yeah, cross-sectional study. It is involved more than 460 participants, the nurses working on ambulance, involving 45 health care facilities. I would like to, in here, this study, I investigated the knowledge, attitude, and practice of ambulance nurses regarding pre-hospital care. So, in here, because I also compare the pre-hospital care providers, the nurses working in hospital and working in puskesmas. The thing that in circles is the interesting result in here. Like I said before, like the nurses working in ambulance, there are 2 facilities, the puskesmas, the community health services, and also the hospital. If we see the pre-hospital care, for sure, the majority are coming from the pre-hospital, which is out of hospital. It should be the nurses working on ambulance coming from the puskesmas, the community health services, should be higher in knowledge, attitude, and practice, because they're working on the side of the accidents or emergency situation, because they're working in pre-hospital, not in hospital. But interestingly, in here, the knowledge and practice of those group of nurses working in a puskesmas and a hospital, there are difference, huge difference, and statistically significant that the difference between the nurses working in ambulance in puskesmas and working on ambulance in hospital. Most of the nurses working in hospital has higher knowledge and skill compared to nurses working in the puskesmas. So it's like the opposite of the, the ideal situation, where the nurses working on ambulance based on the puskesmas or hospital, the community must has higher knowledge and skill and attitudes and practice. But this in here, the opposite side, the result. It's quite interesting. It becomes like, back to the mentee, that education and training are needed mostly coming for the nurses working in puskesmas instead of in the hospital, because they are the first line of the healthcare providers coming to the site of the emergency. But in here, yeah, we can see the nurses coming from the hospital has higher knowledge and practice. So it's coming from the Australian Emergency Care, published in 2018. You can see and download more if you want to know. Oops, sorry. Right. So why we start from nurses? Why don't Indonesia start, establishing the paramedic professional in Indonesia, for example? That's the big issue actually in Indonesia, because establishing, oh my goodness, because establishing a paramedic profession in Indonesia is not easy. It is hard to have like a new professionals, because it's long bureaucracy, yeah. Because like I say, like Indonesia is quite wide. It's not easy to have like one system can be applied in all Indonesia, and need collegium, even for emergency nurses, because I mostly focusing on emergency nurses. Even emergency nurses in Indonesia, we don't have any collegium in emergency nurses currently, yeah. So we still under the medical surgical nurses collegium. It is also one of the homework for us as emergency nurses that we need the collegium. And if we want to establish the paramedic profession, we need another collegium, which is also harder and harder. But that's why we start from nurses. Yeah, we empower the ambulance nurses. Yeah, we try to enhance their knowledge and skill in pre-hospital care, either formal degree or informal non-degree trainings or courses. And we start the small project using the pilot project, and hopefully it can be improved and can be apply in the city, and then it can be expand into the states or province level, and then hopefully it can be the the blueprint of training, how to train the nurses working in ambulance in national level. We are trying to figure out this kind of issue, especially in training and education, how to train nurses in pre-hospital care or working in ambulance. So this is the thing that we should to do in Indonesia. Education, again, I do agree with that one. So nursing students in Indonesia need more specific pre-hospital care content in their curriculum, especially in practical skills based on the previous study. And then someone who are already working on ambulance, especially in the puskesmas, yeah, the community-based ambulance, must have like a good in knowledge, skill, and practice how to manage the patients in pre-hospital care. Therefore, a program of education is required, either for undergraduate students and also for ambulance nurses. This is our big homework in here. And in Indonesia, the development of emergency care, yeah, in hospital emergency care is quite good. Compared to emergency pre-hospital or hospital emergency care is not really good. So myself in here quite struggling how to have like to provide the information to our colleagues, the emergency nurses, that we need to improve our pre-hospital care, because the most of emergency care is happening outside of the hospital. It is easy, in quote, yeah. If there's emergency situation happening in hospital, we have a lot of nurses in hospital. We have a lot of doctors in hospital, but the majority of accidents, the majority of emergency situation happening outside of hospital. How we can manage that kind of situation? So the thing that we need to improve, we need to working on it to have like the same baseline information, the same perspective on how to have a better pre-hospital care among us, the emergency nurses in Indonesia. So this is the thing that we already have implemented or developed, yeah, especially within the University of Brawijaya where I'm working. So at least we have 3 projects. At least we have 3 grants, yeah. The first and the second one is coming from Australia. Thank you, Australia, for providing the support for us in developing how to educate the nurses working in ambulance. So the first grants coming from the DFAT Australia, 2015, we're developing a paramedic nurse course for Indonesia, that's the title. And the second one, we piloting the ambulance nurse course in Indonesia in 2016. So this is the picture of this, the first and the second grant. The first grant, I invited my colleagues, yeah, from Indonesia come to Australia, especially in Victoria, in Melbourne. I bring them to the ambulance services, the ambulance station. We are on the road, yeah, roasted on the road on ambulance services, and also we come to the paramedic education, yeah, around Victoria. We went to Latrobe and then Catholic University around city, and also around outside the city of Melbourne. Just to have like an idea how the education itself, how to train the paramedics working on ambulance, and then how it's related to the real situation when they're working on ambulance. And the good thing is that the gap between the paramedic education and the real situation is very narrow. Compared to Indonesia and here, the nursing education and the nursing clinical practice is very huge different. The gap is very huge. That's the thing that we need to, try to, reduce the gaps between the clinical situation and the education level. And the third grants coming from the Paros Singapore. Yeah, currently we still running this kind of grant. The 2018, actually this is 2 years program. Yeah, but due to the pandemic, we just implemented the first quarter of the grant. So we need to figure out more on how to establish, how to train the nurses working on ambulance. So what has been done? Like I said before, that the baseline, the knowledge, a feeling that we are on the same boat. So it's not just Suryanto itself that, okay, we need to improve our hospital care. If, the other nurses, the other, for example, like a emergency medicine doctor, for example, we need to have to have information, have the same, knowledge and perspective in how to deal with, how to make a better in hospital care. So that's why we run what we call is emergency medical services, EMS courses. At least we have like 4 courses, yeah, attended by nurses, by nurses not just working on ED, but also nurses working on PSC, yeah, the doctors, yeah, the midwives, yeah, attending our courses in here. Start in 2019, yeah, we have EMS system workshop, yeah, in Malang, and then we also have this in Central Sulawesi, the other part of Indonesia, in Sulawesi Islands, especially in the North Morowali, yeah, we run a workshop for them how to establish and good and standardize the PSC, because, like I said before, the implementation of PSC is quite vary between area of Indonesia. So in here, we try to, have a good perspective, providing a good perspective and better perspective, correct perspective on how actually EMS system should be implemented in Indonesia. And the third one and the fourth one, we have the in Malang, yeah, on this year, yeah, on May and also on August. So that's the thing that we already run. Based on the situation that not all of Indonesian healthcare providers have the same understanding that we need to improve our pre-hospital care. That's the thing that we need to do in here. Do I still have a time? Oh, good. 5 minutes? Okay, good. Right. So, sorry. Oh my God. All right. So this is the challenges actually. Yeah, this is the challenges that the grand, oh my goodness, that the grand design. As you know that creating something new is always not easy. Yeah, it's not always not easy. That's why we need a grand design. Especially one of the issue is leveling, whether we have like EMT basic or maybe ambulance nurse basic or intermediate or advanced, that kind of things. We need to have like grand design how we can, develop the leveling or the categories of nurses working in ambulance. The second issue is there are several levels of nursing graduate in Indonesia, not just like in Australia, which is undergraduate, the Bachelor of Nurses. In here we have diploma. We have Diploma 3 and Diploma 4, different. And then we have Bachelor of Nursing, the General Nurse, which is 5 years education. And within those 5 years education, we did not really provide them in how to manage patient in emergency care in pre-hospital. It is said, right? Yeah, during these 5 years. And we have like a 4 years academic on campus, and then we have 1 year on clinical practice or clinical attachment. And yeah, we need to improve that one, yeah. And then we have Master of Nursing. Yeah, we have a Master of Nursing, and also we have nursing specialists forthcoming. Yeah, we're still preparing for that one, because the collegium, if we want to establish the nurse specialist program in Indonesia, we have to have a collegium, especially in emergency nursing collegium, and we still haven't that one. So we're still waiting for that one. And the type of courses, it is university-based or non-university-based. It's also one of the issue if we want to establish that kind of education for nurses working in ambulance. Is it degree or non-degree? Is it, a bachelor or maybe like, diploma 4 or maybe advanced nurses kind of things? Or there is no degree, just like a training, for example. That's one of the issue. And how long also one of the issue itself, how long we can train them for nurses working in ambulance. So, this is open for discussion, I'm sorry. Right. Right. How many more minutes? 2, 3, 5, but that's okay. All right, good. Thank you very much, Quentin. So, what's your opinion? So, this is the thing that I want to learn from you, from Australians. That, what's your opinion regarding nurses working in ambulance in Indonesia? And what is your suggestion how to improve the situation in terms of nurses working in ambulance? We do not talk about the, the system itself, but we focus more on the human resources, the nurses working in ambulance. Anyone have like a suggestion or comments on it? Anyone? Yes, good. You didn't have a suggestion. Okay, that's fine. All right. Yeah. So, yes. So actually, based on the regulation that there must be a PSC, the PSC should organize the ambulance services within the area. So the PSC should organize whether, okay, I will involve all the ambulance vehicles coming from hospital A, B, C, and also the clinic coming from that area, or puskesmas that kind of area. Because not all of the area have the kind of system, the PSC, so most of the ambulance coming from the hospital-based ambulance, that's correct. Yeah. So how is actually the people access that kind of services? They should call directly to the hospital. And some of the hospital, if they want to call the ambulance, they will go to the front office, yeah, and the call taker, not directly to the ambulance. And then, okay, where are you going? Okay, I need the ambulance. All right, wait, I will transfer to the ambulance department. Go to the EAD. And then, okay, this is emergency department of hospital, blah, blah, blah. What do you want? I need the ambulance. Okay, I will transfer the ambulance services. So it's like a long way to go, yeah. That's why one of the research I didn't put in here, the majority of patients coming to the ED of the hospitals not using the ambulance. Only 11% using the ambulance. Most of the majority using the patient coming to the hospital using the private vehicles. And some of the, before the pandemic, some of the patients coming with the public transport, without any treatment during the from the accident site to the hospital. That's the real situation in Indonesia. Okay, good one. And the puskesmas also have the worst situations because the image of the community itself, that the puskesmas do not really good ambulance vehicles compared to the hospital. That's why they they will not call the ambulance coming from the puskesmas, because they will know that they already know that there's nothing that can you do from the puskesmas. That's why they call directly to the hospitals. Even if the area already have the PSC, not really not all the community aware about that kind of systems. Yeah, so only thanks to the COVID pandemic, yeah, because of the PSC, yeah, getting more popular during the COVID pandemic, because of when there is like cases of pandemic, the COVID-19 in the community, the PSC will come to the side of the patient. So that's become, the establishment of PSC in Indonesia more popular during the pandemic. So that's become, the people, okay, there's a PSC. Before that one, they do not know that it's PSC, and they do not know how to call the ambulance. They do not all Indonesians do not know that 119 is the number that they should call during the emergency situations. So that's the thing that we need to improve in terms of the community awareness, how to make people in Indonesia more educated, that well-informed, not educated, yeah, well-informed that the 119 is one of the number that they can call during the emergency situation. All right. Okay, good questions. Yeah, it really depends on the PSC itself. Yeah. So for example, in my hospital, yeah, I mean Brawijaya University Hospital, they have at least 3 people. Yeah, not at least, usually 3 people, 1 driver and 2 nurses working in ambulance. But not all area have that kind of things. Yeah, not all area that kind of things. So sometimes they have only 2 nurses and 1 become the drivers and 1 become taking care of the patients. So it really depends. And some of the area, especially in the puskesmas, only driver will goes to the area because limited sources of human resources working on the puskesmas. Because if the puskesmas have inpatient facilities, most of the nurses working in the puskesmas, not going to the site of the accidents, just in a small portion of the area. Okay, good questions. Come from here? Yes, sir. Do you mean the salary? Okay, there is no difference actually. So the PSC itself, so because the situation just like this one, the PSC is actually should be organized by the Department of Health within its city, yeah. So and the hospital usually is not belongs to the city health department. Some of the hospital coming from the provincial department, and sometimes the hospital coming from the national government, that kind of things. So the local area do not really, power how to, hey, even though you're coming from the province or national, you should follow our regulation. Sometimes they cannot force that kind of things. So, and if they only have the healthcare department of each city, they have their own puskesmas. The puskesmas under the health department, and if they force the puskesmas, hey, you have to work within that kind of system. You have, deploy or maybe involved in that kind of system. Sometimes the nurses working in the puskesmas only have like a lot of works, and sometimes they, if I speak with one of the nurses working in puskesmas, I don't know what that kind of systems. It's kind of like burden for them. Just like, it's adding a lot of things, that kind of things. So that's the thing that we need to improve as well, that not all nurses have the same information as perspective and how to deal with the pre-hospital care in Indonesia. And in terms of that one, so most of the PSCs, just like in Malang, they hire outside from the, because the Department of Health usually are coming from the hospital, coming from the government. And the nurses are government employee. And because they already work in puskesmas, they already, okay, enough, I don't want more work. So they hire coming from outside, and it's small wages, small payment, compared to nurses working as government employee. So that the things that, every single city do not really implemented the PSC itself. So during the shift, during the shift, hours during the shift. So in Indonesia, we have 3 shifts in a day, yeah, in majority. And start from 7, not like in Australia, which is only 2. I'm not sure about the other in Western, but in Victoria, they have 2 shifts in a day, which is 12 hours. In here in Indonesia, we have 3 shifts, which is from 7 to 2, and 2 to 9, and 9 until 7 in the morning. So that's kind of different shift. On hospital. Yes, exactly the same, just like that one. Yes. Uh-huh. Because some of them, yeah, are nursing graduates, which is in Indonesia, there are a lot of nursing education institutions, and a lot of nurses are graduates every single years. So if they want to have like a good salary, it's quite hard. It's like, competitive. And then if there's a chance, there's an opportunity to work on PSC, even though it's like a low salary, that's fine, as long as I can get a job, even though it's like a low salary. So that's some of the them have that kind of situation. And also the worst thing is what happened in Malang is that because in Malang area there are a lot of volunteers, yeah, a lot of volunteers, and the PSG of Malang city, they ask those kind of volunteers, especially you know, the leaders or the coordinator of that kind of volunteers, ambulance volunteers, going to the PSG, and they don't have any you know, healthcare providers background. So for example, in Malang is just like the area, the big area, the city is quite similar about the Melbourne, yeah, and we only have about like 15, I guess, or maybe 16 providers in that PSC for the area of Malang City. For sure, it's cannot, you know, handle all of the emergency situation, just like in Melbourne. For sure, it's kind of, you know, yeah, it doesn't work. Yeah, it doesn't work, and yeah, for sure, yeah. And some of them, the nurses also like 7 nurses out of those 16, and also 2 midwives. The other are non-healthcare providers, just like volunteers. So that's the situation, yeah. So that's why we need to, you know, just like you say, education, training, that kind of things, yeah. Okay, anything? Yes, good. It is free of charge. Yeah, it is free of charge because it is under the health of department of its district. So the thing that we can have like a grant from international one, just like how to educate them, that kind of things. Just like what the grant that I already have, that kind of things. So yeah. Yeah, time's okay. I know that you want to have like a closing party. Yeah, right. So I think that's it. Yeah, thank you very much. Yeah, give a round of applause to all of you. Yeah, thank you very much to Dylan and also Quentin. Yeah, again, have a good night and thank you very much for me. Yep, thank you.
And thank you, Suryanto. And if anyone does have any further questions, sorry to cut you off there. I'm sure you'll be hanging around there a little bit, so feel free to have a chat. So that does bring a close to the formal part of the conference. Big thanks once again to all our presenters, especially for putting up with a possessed clicker, which we changed 3 times and still caused us many issues. So thank you very much. And finally, thank you to everyone in this room and everyone who registered for making this conference happen, where 6 months ago it looked like no international travel and nothing was going to occur. So I really appreciate everyone's faith in getting on a plane and getting over here. So enjoy tonight. Safe travels home to everyone who has to fly home soon. For those staying on in Bali, I'm very jealous. Enjoy the rest of your trip and hopefully we'll see you all at a future conference. Cheers.